Now, I'd like to request our next speaker, Professor MG Azam, to give his presentation in the topic of heart failure and ACS. Professor MG Azam is the cardiologist from NICVD. He is also scientific secretary in BSCI. Professor MG Azam, sir, please share your slide.
Am I audible?
Yes, sir, you are audible.
Thank you, dear moderators. I must give a special thanks to Professor Abdul Qadir Akundo and Dr. Amir Jamal Lablu and Dr. Mahmoud Firuz give me the opportunity to be here with you with my talk, heart failure and acute coronary syndrome. This is my potential disclosures. You know, I am not a promotional speaker for any company, but we do accept snacks or any evening tea in our presentation at Hotel Shodar. Just for fun. Okay. Acute coronary syndrome and acute heart failure is a diagnostic dilemma, and it is a not rare combination, it is the most common combination. And as you know, heart failure and acute coronary syndrome are the global epidemics. If you look at this left panel, heart failure prevalence around 1.5 to 2.5% all over the world, daily increasing day by day. Similarly, acute coronary syndrome also a global epidemics increasing prevalence all over the world, mostly South America and South Africa, and in the North America it is around 20 to 40% prevalence, and in India and Bangladesh like it is around 20% prevalence. So if you look at this epidemiology of the acute heart failure with acute coronary syndrome, the incidence of ST elevation MI with heart failure almost similar to non-ST MI around 15.6 versus 15.7. It is slightly reduced in unstable angina. But if you look at the case fatality of the heart failure and acute coronary syndrome set expressions, whatever the STMI, non-STMI, unstable angina, if you look carefully during ST elevation MI with heart failure admission or during hospitalization heart failure observed or any time heart failure, case fatality is higher than other cases like non-STMI and unstable angina. If you look at this slide, these all slide from the registry data, from the GRACE registry data, and this is the prognosis. If you see from admission to at the 6-month follow-up, the person who are present with acute coronary syndrome with heart failure at admission, it is around 21%, and the acute coronary syndrome without heart failure around 7%. It is 3 times greater in acute coronary syndrome with heart failure patients. So it is very significant and very dangerous. Similarly, if you look at this right panel, heart failure with admission, it is around 15% and or 14.7% like that. And if it is look at this year heart failure during hospitalization, it is around 21%. It is also significant. But interesting data was observed from the GRACE registry. During hospitalization patient, if you treat it by reverse version studies in the form of PCI or whatever you like to say, CVG, reduce mortality significantly. It observed the person who get treatment by revascularization strategy observed mortality rate 14% only, and the person who didn't receive any revascularization treatment mortality rate 23.7%. So it is very significant. That is why we are here today. If you look at this 5 years mortality events observed in case of reduced or preserved or borderline heart failure situations, critically analyzed, you can see 75% patient may die from these heart failure conditions. What about the irrespective of heart failure status, reduced, borderline or preserved ejection fraction, whatever you say. So it is very deadly disease. We should give very emphasis. We should be very careful for our patient management. All you know, the stages of heart failure and annual symptoms are almost correlated in every situation, but it is confounding when it is associated with acute coronary syndrome. You know, acute coronary syndrome and heart failure presentation confusing and almost confounding by any other clinical situation. That's why it is very critically we should evaluate to manage our patient for getting better management strategies. This is the universal classification. As all you know, the universal definition classification, it is the new classification. If it is based on the ejection fraction, if less than 40%, it is termed as heart failure reduced ejection fraction. And if it is more than 50%, it is called preserved ejection fraction. If it is in between, that is called heart failure with mildly reduced ejection fraction. Interesting subset is found newly heart failure below 40% initially if treat you by appropriate drug and increase more than 10%, that is termed as heart failure with improved ejection fraction. Most interesting thing is that you look at the right side. This is the data from the Grace registry data. Television MI, especially acute coronary syndrome, present with heart failure, mild to moderate heart failure, found LV dysfunction 20 to 25% cases, and severe LV system dysfunction we found 2 to 13% cases. And some extent, we are severe form of heart failure, actually cardiogenic shock present 5 to 10% cases observed. And this is the clinical phenotype and etiologies of heart failure. If you look at here, then you can see the most common cause acute coronary syndrome is the heart failure. It is the Latin American study, but it is global. If you look at it, it is around 60 to 70% case of acute coronary syndrome resulting heart failures. If you look at the pathophysiology critically, primary cardiac insult most commonly due to acute coronary syndrome, then it may cause myocardial dysfunction, leading to various pathophysiological changes and stimulated neurohormonal system that may cause stimulation of various pathways and causes sodium and fluid retention, vasoconstriction in the peripheral vasculature, and cause adverse cardiac remodeling, cardiac myocyte result worsening cardiac functions that may lead to serious morbidity and mortality of our patients. If we understand the pathophysiology and rightly interpret these multiple pathways by various drugs, so we can easily overcome these situations and improve our quality of life. If you look at this, what is the optimum treatment optimization issue? As you know, acute coronary syndrome, which is a different subset, but in chronic condition, you can optimize whether it is compensated or non-compensated. As the acute coronary syndrome does not differ from the acute coronary syndrome management strategy as well as heart failure strategy, polypharmacy is the big issue to management of these particular situations. Of course, sequencing of drug also another issue, and we have to individualize that tailored to our therapy according to our patients. Priority and goals should be the paramount importance. What is the challenge from our clinicians? Trials. Yes, we have enough trial in regarding heart failure management, but ACS and acute heart failure, we don't have enough data. We have to depend on the registry data. Choice of drugs was another issue. Of course, interaction, efficacy, and safety profile of newer drugs should be critically evaluated. Now, question is that whether we should start many drug at low dose or few drug at higher doses. That is also another issue. Dear friends and colleagues, if you look the principal and physiological targets of heart failure to select your pharmacotherapy, as I said you earlier, the pathophysiological process stimulated by the neurohormonal system interfere this 5 pathway. If we can modulate this 5 pathway by fantastic 4 drug as recommended by ACS and AHA, RNA beta blocker, MRA or SGLT2 inhibitor with that fantastic result. Sometimes we don't control our heart failure situation in some other region. There may need other additional drugs like ivabradine and hydralazine or vericiguat in indicated cases. So we should be judicious to our management strategy. How you can sequencing our drugs, as you know, SC inhibitor, beta blocker, MRA, RNA SGLT2 inhibitor. Initially, it is older sequences. Usually need to 4 to 6 month time to sequencing your drug to get your optimum result. Now, new sequencing is advocated. You can start by beta blocker or RNA or MRA, then SGLT2 inhibitor, 1 to 2 weeks follow up, and you try to reach up within 4 weeks to maximum tolerated doses to get better benefit. Either you can use it or another you can use it beta blocker or SGLT2 inhibitor plus early or MRA. You also similarly achieve within 4 weeks by 1 to 2 weeks interval follow up. Dear friends, now question is whether we should go for many drugs at low dose or fewer drugs at higher dose. If you look at this biostat congestive heart failure registry data, lower dose of combined treatment with associated with better outcome than 100% of either monotherapy. If you look at this meta-analysis from 58 randomized clinical trial, of course, monotherapy is good, like as SC inhibitor or ARB or beta blocker, whatever you say. But it is much more add-on beneficial effect you get found by combination therapy like RNA, beta blocker, or mRNA like drugs. So we can summarize in that particular situation, we should target multiple pathways and start low dose and individualized medication sequencing based on the patient's status, especially volume status, blood pressure, heart rate, potassium, and GFR. monitor frequently for changes, and we should aim for randomized clinical trial. Target doses or highest tolerated doses that will allow our patient to maintain ambulatory unit. And most confusing situation, especially when acute heart failure with acute coronary syndrome, there are usually four classical subset usually we face in our practice. Patient with acute heart failure with chest pain with normal troponin, patient with acute heart failure with elevated troponin but without chest pain. These two subset you can tackle by further investigation. If you know not found any early invasive strategy requirement criteria, then you should keep them in conservative treatment strategy. But thing is that when patient with acute heart failure with chest pain with elevated troponin and ECG shows estimation MI, you should go for primary PC strategy. If not possible, then go for thrombolytics. And if it is you found it is non-ST elevation MI, that you should consider the early invasive strategy. Dear colleagues, in this COVID era, type 1 and type 2 MI, you cannot differentiate. The angiography is the only answer how to differentiate type 1 and type 2 MI, as well as you can treat this other confounding treatment variation. This is the most important thing, especially with ACS. You should treat it properly, that you should optimize your heart failure management. Otherwise, patient develop difficult heart failure. I show you two wonderful case. It is one case, 66 years male, attend our hospital, ST elevation MI with unstable hemodynamics. His disease was infiltratal ST elevation. His baseline ejection fraction around 45%. He underwent cath lab and found LED 100% occlusion and RC also 100% occlusion. As a primary picture strategy, he picks up complete devastation, RCA and LED as well. And this is the final result after discharging. This is the final result. After discharge, during the discharge, patient kept on deputy statin, beta blocker, ACE inhibitor, and MRA, and diuretics off and on. But during the discharge PCI follow-up, echo was found 52%. That is around 7% EF is gained during hospitalization. If you look at our second case, this is 53 years male, ST elevation MI, attend our hospital and tackled nicely by primary PCI to LED, and subsequently follow up after 14 months. He presented to our hospital with worsening heart failure situations, found his ejection fraction was 33%, and his end terminal probeat was 35,000, and ECG shows complete LVO with QRS duration more than 160 milliseconds. That's why that's time we plan to implant a CRTD, and this is the video. Sorry, this is the running. Okay. Then we kept the patient fantastic 4-drug RNA, 50 milligram VD and carbidopa 12.5 milligram VD and SGLT2 inhibitor, empagliflozin, and also MRA 25 milligram VD. Then patient discharged with echo and found ejection fraction was 43%. Dear friends and colleagues, that's why we are advocating time-dependent therapies for post-MI patient with heart failure patient. It is very much important to determine how timely fashion we should treat our patient. In 0 hours, acute coronary syndrome with heart failure, definitely it is undertreated. We should emphasize aggressive treatment like PCI, primary PCI, if facilities there, not lytics. If it is non-STMI, they go for early invasive strategy. Our primary target to start ACE inhibitor and beta blocker within 24 hours is because the presentation is heart failure, then we should not give beta blocker first 24 hours. We should reevaluate after 24 hours whether the beta blocker therapy should be feasible or not. But we should start ACE inhibitor or RNA, whatever you like, whatever you have facilities. You should start as soon as possible. Then you should start MRA within 7 days. That gives the mortality benefit. Of course, beta blocker 30%. And ACE inhibitor also go 30 to 34%, and aldosterone antagonist also give you 1/3 mortality benefit. Then the crucial event when you give a discharge, then you should make a proper follow-up plan to optimize your maximum medication within next 4 weeks. This is also elaborated presentation of this previous slide. If you look at this beta blocker should not be considered if you have the cardiogenic shock risk. If more than age 70 years, systolic blood pressure less than 120 or tachycardia more than 110 or heart rate less than 60. Dear friends, we should remember our target to start beta blocker as soon as possible. But our target to achieve our targeted heart rate on the top of to achieve the maximum guideline directed dose. ACE inhibitor also similarly, you should add ACE inhibitor by keeping blood pressure above 100, and if ejection fraction less than 40%, definitely patient has mortality benefit. Also ARB also you should start, aldosterone antagonist also you should start. My importance is early revascularization should be as soon as possible. The only therapy proven to reduce mortality in MI patient presenting with cardiogenic shock. But one thing we should remember, in MI setting, routine use of IVP is not indicated to reduce infarct size or to manage cardiogenic shock. This is also very important things. If you see the acute heart failure with acute coronary syndrome, we usually find in our clinical practice 5 to 10% in severe cardiogenic shock. If we left it is untreated, 70 to 90% patient may die. If we treat by intervention, early invasive intervention, then we can save some potential lives. It is proven by published randomized clinical trials, especially post-hoc analysis from the EPSIS trial, showed it reduced all-cause death, cardiovascular death, sudden cardiac death. But question is that whether it was gain of ejection fraction. Multiple registries shows in hospital, ejection fraction may improve if you do in hospital setting 2% to 8% and post-discharge setting 3% to 12% may be improved. So we should give emphasis in this particular group. We should treat appropriately, but in other situations like shock with mechanical circulatory support system or chronic heart failure condition, it is not proven benefit, but we have to wait for long. If you look at this, if you look at the shocking data about the shock, despite huge advancement in revascularization, pharmacotherapy, and mechanical devices, mortality of shock has remained constant for 50% for last 3 decades. Don't be
Sir,
panic,
time's
but
up.
you treat.
Already 1 minute time's
This
up.
is my last slide. This is my last slide. Thank you. And this is my take-home message. Heart failure is a common and ominous complication associated with all form of ACS. One should remember ACS and acute heart failure are undertreated and need more aggressive treatment strategy. The initial pharmacological management of ACS in patients with acute heart failure should not differ from standard pharmacological treatments. First of all, lower dose of combined therapy is associated with better outcome than monotherapy. Therapeutic change should be justified in symptomatic patients. Dear friends, as we are clinician, we should practice evidence-based medicine, but we never forget to tell our patient, take all this pill daily until a new clinical evidence, a new clinical trial is published. I think I should stop here. Thank you very much.